Hello, everyone, and welcome. Today, we're going to be focusing on Chapter 12, all about challenging clients and demanding situations. So, for most clinicians, when they first start off, they really want to work in settings where they have cooperative clients. These settings are primarily in an office, and it's something that is familiar and comfortable to us. But many clinicians learn to love working with clients who challenge us or situations that may offer a little bit more chaos than comfort. As of the time of this recording, especially with everything going on with the pandemic, we find that many clinicians are now working with people remotely. Whenever we have any kind of change that occurs, it can be really jarring at first for clinicians. But as they experience these situations and these clients that fall outside of the realm of what they had envisioned, doing or working with, a lot of clinicians find that they really do prefer challenging clients and more demanding types of situations. So, this chapter is going to focus on interviewing challenging clients and working in more demanding situations. So, by the time you're done watching this video and reading chapter 12, you'll be able to describe resistance as a naturally occurring phenomenon in therapy. You'll be able to identify and apply specific techniques for working with resistance. You'll be able to describe methods and guidelines for the assessment and prediction of violent behaviors, describe the psychological first aid or PFA model, and finally, be able to discuss cultural competencies in disaster mental health, including cultural humility. So, when we first think about challenging clients, some clients are super eager for therapy, but in many cases, others are less enthusiastic or willing to be in therapy. So I want you to close your eyes for a second and imagine hearing some of these openers. Do I have to be here? No disrespect, but I hate counselors. I'll never talk to you about anything important. This is a shitty little office, so you must be a shitty little therapist. For many of these clients, something to think about is that if you are experiencing anything like this, you may find that this is a client who is resistant. And when we think about resistance, something to think about is that for anyone who has ever performed therapy, you've run into this. When you have a resistant client, you often can leave the session feeling like you just spent the therapeutic time with them banging your head against the wall. And it can be highly stressful and frustrating. So, resistance in and of itself, or the idea of resistance in therapy, is actually more complicated than we think. It was originally created as a psychoanalytic concept by Freud, who believed that resistance was an unconscious opposition to revealing memories in psychoanalysis. In more general terms, resistance is thought of as anything that stops therapeutic change. It's traditionally been thought of as an unwillingness, either consciously or subconsciously, of the client to grow. More current definitions, however, position that resistance is not just the fault of the client, but is a product of the therapeutic relationship. If the client is exhibiting resistance, it's part of the job of a therapist is to assist in reducing this as much as it's the client's responsibility to change their behavior. So, whatever your definition is, one thing is for sure that resistance is negatively related to treatment success. So, in our book, we also look at the death or reframing of resistance. So, DeShazer buried resistance in his backyard, and Miller developed motivational interviewing, which we're going to talk about in a little bit. So, again, when we think of this, resistance is part of the therapist engagement or lack thereof. It's part of the client's issue, and it's also partly a part of the situation overall. So your client may have been in therapy in the past and had negative experiences. They may truly be unwilling to change because they like the status quo, even if the status quo is not healthy and is actually harming them. They may they may have had negative experiences in the past when it came to change. So they're really not willing to make that change. So, what are let's take a step back. So, what are some common signs of resistance that you can find in therapy? So, the first is not talking. And for every therapist, one of the biggest fears that we have when it comes to therapy is a silent session. Although complete silence is a rare occurrence throughout an entire hour-long session, it's not unusual to find that a client will give short answers and has a difficult time opening up. Another sign of resistance is small talk. Some clients will talk extensively, but it's about their weekly activities and other inconsequential information. When they're guided to talk about thoughts and feelings, they will tend to avoid engaging in that conversation or distract you by moving on to a different topic. When it comes to really challenging them to try to have that conversation, they may even shut down. Another is a client who doesn't do homework or doesn't use suggestions. So, when we think about therapy, in many forms of therapy, it's popular to give homework. So, a telltale sign of resistance is a client who doesn't complete their homework or follow up on your suggestions. In order for therapy to be successful, a client needs to at least think about what was discussed in a session in their daily life. Not doing homework is a sign that they're forgetting about the session as soon as it's over or unwilling to complete the tasks outside of that session. Another sign of resistance is canceling sessions. Almost all clients cancel a session from time to time, but when a pattern develops, it can be a worrisome sign. Someone who is motivated to change will make attending sessions a priority. For those who are resistant to change or not ready to make a change, you may find that as soon as you have a what you perceive as a breakthrough in the session, they then cancel the next 2 or 3 sessions after that. Another sign that there could be resistance is when you feel like you're spinning your wheels. This is when you feel like the client's not making progress. That is a clear sign of resistance. They may come in regularly, but they keep having the same experiences and don't show any improvement. Another thing for you to think about as a therapist, you may try harder than your client. When you feel like a client is not making much progress, it's natural to feel frustrated and even a bit guilty. You want to make sure that you're providing them with the best therapy possible. So you spend extra time on their case, planning new strategies and interventions. But unfortunately, the client doesn't seem to be making much effort other than showing up for treatment. Remember, therapy is a two-way street. If you're working harder than your client, it's probably not going to go anywhere. So, we're going to talk throughout this chapter about how you can address resistance in therapy. So, let's now talk about motivational interviewing. And when we talk about motivational interviewing, or MI, is a counseling approach that was developed in part by two different psychologists, William Miller and Stephen Rolnick. When you think about motivational interviewing, it's essentially a directive. It's a client centered counseling style, and it helps to elicit behavioral change by helping clients to explore and resolve not only ambivalence, but also resistance. So, when we think about this, there are some there are some basic tenets that we think about when it comes to motivational interviewing. So, there are these guiding principles, so to speak. There's four of them. The first is expressing empathy. This is where you help the client to help facilitate change through acceptance. There's also skillful reflective listening that can happen from you as the therapist to the client. And by modeling that, it can then help to allow the client to not only strengthen that therapeutic relationship, but then to also open up more. You may also find as you're expressing empathy that your client may exhibit ambivalence and resistance, and that's okay. The next guiding principle of motivational interviewing is to develop discrepancies. So think of it from this perspective. The client, rather than the counselor, should present the arguments for change. You can help your clients to come up with how they would want to change, but you want the client to really dive in to think about what would those changes be and what would they look like. Change is then motivated by a perceived discrepancy between the present behavior and the important personal goals or values. So they have to not only think about these changes, but then look at What changes do they want to see versus where they're at now? How can we then help them to look into the future once they start seeing those, once they perceive what those changes might look like? You also want to roll with resistance. So avoid arguments and make sure that as you are avoiding arguments, that there's not a lot of opposition from your clients. If you find that there's a lot of opposition from your client, try to meet them where they're at and guide them accordingly. When you think about new perspectives, these are invited, but they're not imposed. So you essentially use a tactic of asking questions that will help to elicit them to think about these changes or what these changes could be, and then imagine once they've achieved them what this might look like. And finally, resistance is viewed as a signal to respond differently. So, as we talked about in chapters 5 and 6, that you can ask certain types of questions to challenge our clients. Part of rolling with resistance is to also gently challenge them to think about how they might respond differently and what that might look like. The last guiding principle for motivational interviewing is supporting self efficacy. So, you want to help a person believe in the possibility of change. And that can be an important motivator for them to let down ambivalence, or to let go rather of ambivalence, and to let go of resistance, let down their walls, and actually start facilitating change. It's the client's job, not the counselor's job, for choosing and carrying out change. So, again, I know that it can seem really frustrating, but you never want to work harder than your client. It's also important for you as the counselor and your own beliefs in the person's ability to change, because if you believe in them, then that can become a self fulfilling prophecy for them to elicit change. If you don't believe that they can change, that too can become a self fulfilling prophecy that they may believe that they can never change. So, when we think about this, the ways in which you elicit these responses can help clients to engage in change talk and even sustain what they're saying. So, what are some strategies for working with resistance? So, the first thing are different types of questions. So, giving them some open questions, opening questions, and goal setting strategies. So, you want to begin the intake interview in a positive, strength focused, empathetic, and non blaming manner. So, you can ask them questions like, what would make this a helpful visit? If we have a great meeting today, what do you think may happen? What needs to happen in here for our time to be productive? So, you are gently challenging them, but you're leaving it up to them as well to think about what it is that they need in order to make this time essentially go by quicker. You can also use reflection, amplified reflection, and undershooting. So, when we think about reflection questions, you are going to be asking questions that ask them to reflect on something that you may have talked about, something that you may be trying to talk about. So, you want to, give them different questions that can be, what am I grateful for? Or you can ask them, what are you grateful for? What are your values? Where will you be in 1 year or 5 years or 10 years if you continue doing what you're doing today? So that's part of that reflection. And when we think about that, that can be really important to ask them, because when you are trying to get them to think about where they are now and where it is that they want to be, that can then help them to facilitate change, because where it is that they want to be, that's something that they are showing that they have a desire to work towards. When you are talking about amplified reflection, this is where you can reflect back to your clients what they've said in sometimes an exaggerated or even an extreme way. So, when you are using reflections, these are allowing your clients to know that you are hearing them and that you are When we think about reflection versus amplified reflection and reflection questions, this is simpler or even a very direct reflection of what the patient states. And this can help to assist in eliciting change talk. But amplified reflection occurs when the therapist makes a reflection that overstates what the patient has said. So this can help, the patient or the client see through ambivalence and arrive at change talk. So that might, for example, be, well, you say that you want to buy a home, but what do you think needs to happen for you to buy this $2 million house in the next 10 years? What kind of job will you need to have? How much money will you need to put aside? So you are giving them this amplified reflection in a way that is getting them to know that you are listening, that you are being present with them, but that you're getting them to elicit these different types of questions. So we also have undershooting. So when we think about overshooting and undershooting, right, these are useful reflection techniques where different statements can be offered back to the client for more personal exploration on a particular topic. So these techniques can be particularly helpful when there's an emotional content involved. So Miller and Rolnick talk a lot about in motivational interviewing about the word anger and lower intensity words like annoyed and irritated, and higher intensity words like outraged or furious. These words can also be diminished or increased by adding words such as a little or a bit or very or extremely. So when we think about undershooting, it's important for us to think about overshooting. So if the client's talking about the way that their mother tells them how to raise children, overshooting can say, "You're really furious with your mother." And then they can offer a response like, "Well, no, I wouldn't say furious. I'd say angry. She's my mom. I can't really be, furious with her." That's an example of overshooting. Undershooting is essentially the the other way around. So if a client says, again, "I don't like the way that my mother comments on how I raise my children," you can say something like, "You're a bit annoyed with your mother." And your client might respond with, "Hell yeah, hell yeah, my mom is a pain in my butt. It irritates me to no end and how she's always correcting me and criticizing me." So by undershooting that emotion, you're eliciting these changes for your clients and you are bringing out their emotional component. And as we've talked about throughout our class, that if your client can connect with an emotion and identify that emotion and feel that emotion in session, that can be the catalyst for change because they don't want to be a little bit annoyed with their mom. Maybe they're really annoyed with their mom, or this person doesn't want to be angry with their mom anymore. "I'm tired of being angry at my mom." So using these different types of reflection through training and motivational interviewing can help to elicit those emotional responses. You also have this notion of coming alongside. So, this paradox involves prescribing the symptom. So, a traditional paradox would look like, "I think maybe you're not drinking enough." But in motivational interviewing, they Miller and Rolnick really caution against the paradox, but allow for you to come alongside. So you may say something like, "It may just be worth it to you to keep on drinking as you have, even though it causes some problems. It's worth the cost." So you're recognizing that there could be a potential concern or issue, and you're kind of joining them a little bit in order for them to in the future elicit these changes. You can also use things like emotional validation, radical acceptance, reframing, and genuine feedback. So, when we think about these strategies in motivational interviewing, something for us to think about, or something for us to note, is that these are specific terms and these are essentially ways that you can be trained to help guide your clients. So, when we think about emotional validation, you are essentially thinking about how, as part of these, as part of this validation method, I should say, that something that we think about is that you are essentially confirming that what they are experiencing and how they are experiencing this can, be it's worthy, and that you're hearing what they're saying. It's a way for you to affirm to your client that you are paying attention and that you hear what they're saying and that they're not alone in feeling this way, and that it could be a more common experience that people have. When we talk about radical acceptance is actually a principle and a technique that's based on dialectical behavioral therapy, as well as person centered therapy. And it's essentially the radical component is where you mean something completely and totally. And that in accepting this and in getting to the point where you are in where you are truly accepting it, you accept the good and the bad, the pros and the cons, and that you just recognize that it is what it is, and that you may not be able to change that situation, but you can change your reaction to that situation. When we think about reframing, reframing is a skill that will allow you to essentially offer a new and even a more positive interpretation of the negative information that is provided from your client. So you acknowledge the validity of the client's raw observations, but you offer a potentially new meaning. So if the client says, with me losing my job, I'm hopeless and I'll never get another job again, you may say, well, when one door closes, another one opens. So maybe your next job will offer you better benefits and even more pay. That can get them to think outside of that raw emotion and that raw state to think about, well, maybe if I apply myself, or maybe if I, look for different jobs, or maybe if I go back to school, I can get a better paying job with better benefits to support my family. And when we talk about genuine feedback, we are looking at how we are offering these abilities, so to speak, to be transparent with our clients and to let them know that you hear them and you validate them, but you also see other sides as well. So when you're giving them the feedback, it's your tone and it's the language that you use and your verbal and nonverbal skills that tell the client that you are there with them and that you understand their pain and that you're there to support them. But there's also other ways that you can look at this, which may be more difficult to be able to essentially understand or to even sit with. Part of the part of the thing with genuine feedback is also the love reframe. So when you think about the love reframe, we are thinking about how in the love reframe that you are offering this new and this positive way of looking at something, but you are also giving them the love that comes behind it. So they can hear what you're saying and be present with you, but also understand that you're coming from a loving, caring place. Part of the love reframe is also allowing clients the opportunity to understand that you can get through these more challenging situations, and that through getting through these more challenging situations that you have the ability for them to understand that while things may be difficult and while things have been challenging, or why someone may feel rejected, by being able to be there and to be present and to show them love and to let them know that they are a loved person and that they have this ability to learn from hurt and rejection can help them to make these overall reframes in their life, which can better them as individuals. You can also find different ways to deal with resistant clients who may be lying or even delusional. So, you want to invite what are called collateral informants. Collateral informants are essentially um, someone who is very close to the person. That could be a parent, or that could be a peer, or a romantic partner, or a friend, who can essentially provide some more background information about the client and their current situation. So, for example, if your client keeps saying, I can't decide, without more information, or my job is to understand what your views are, you can then use the collateral informant to help educate them and to get some more background information so that you can help them to keep an open, you can help them to keep an open mind, at the same time letting them know that getting this additional information can be really helpful, because your client may only be able to see something from a one-sided perspective. They may only see what it is that they're seeing that's part of a defense tactic. So by inviting other people in, you can get a more enriching picture. So if your client, going back to the client who, thinks that they'll never find another job and they'll never make any money again, by bringing in their parent or their friend or their roommate or their romantic partner, you can help them to understand that part of the reason this person was fired was because they were constantly late to work. They kept missing a lot of days because they couldn't get out of bed, or that they would take longer breaks than what was allowed, and they finally got fired as a result. Well, you can then go back and work with your client on what was happening that caused them to be late, or caused them to take longer breaks, or caused them to not go to work, and then address those things while they're looking for another job so that they can prevent from engaging in those types of behaviors at their next job. By getting these collateral informants, it's a way to enrich in the client story and give you additional information that can then help you to help the client. And again, you can tell them, my job is to understand what your views are. So by bringing in your roommate or to bring in your friend, that might help to enrich the situation. When you're interviewing clients who have SUDs, or substance use disorders, or issues, the best thing that you can do is ask them the CAGE questionnaire. So the C is, have you ever felt that you should cut down on your drinking? The A is, have people annoyed you by criticizing your drinking? The G is, have you ever felt guilty about your drinking? And the E is, have you ever had an early morning or an eye opener drink first thing in the morning to steady your nerves or to get rid of the hangover? If they answer yes when it comes to these CAGE questionnaires, if they answer yes, then that is a red flag that this is someone who may have um, an issue or a concern. Um, so this essentially tells us that the higher their score, that they have a sensitivity or a specificity towards excessive drinking or even the identification of alcoholism. So when you think of this, this can be the beginning of understanding that there's some unhealthy behaviors that could be occurring that can cause the client to not be living the best life for themselves. So, what you can do with motivational interviewing is to be sure that when you're talking with your client who has substance use issues or concerns, that you always ask permission. If you're going to be talking to outside people, you want to make sure that you are um, getting written consent, but you ask permission to talk about the concern or the issue. By not asking permission and not allowing your client the opportunity to say, yes, let's continue, or no, I don't want to talk about it right now. If they say no, that's a red flag, something you can return back to later. But if they say yes, you want to make sure that you get that buy-in so that they're going to be more open with you rather than just dropping on them. So, do you think you have a drinking problem? Your client might look at you and be like, okay, I'm done here. You also want to ask about a typical day or a typical drinking session. So, what does that look like? How often are they drinking? what's going on for them. When they drink, what do they drink? How much do they drink? What's the time frame in which they're drinking? Do they ever get behind a wheel, or do they have a backup plan set up before they leave? Are they engaging in other high risk behaviors? These are things that you want to know. So that's part of that lifestyle. Also, what are the stressors that are causing them to drink? You ask them about their health. What is their physical health like? Are they having issues, um, maintaining their weight, or are they gaining weight or losing weight pretty rapidly? Do they have a family history of any kind of substance use disorders or excessive drinking or drug taking? You want to ask them about, do they work out? What are some of the people that they have in their life, or what are some of the social supports that can, support them through these things? You want to also talk about good and some less good things that are happening in their life. So you may find, especially at the time in this video with the pandemic, that things like the pandemic and everything that's gone with it, with the loss of jobs and, isolation and withdrawing and quarantining, that these things may impact someone's thoughts, emotions, and behaviors, which may lead them to engage in things to help essentially escape reality. So, when you're asking these questions, you want to make sure that you're also asking those types of questions to get that full picture of what this looks like. Because this could be acute, meaning short term and situational, or this could be more chronic and problematic behavior. So, when you're assessing and even predicting violent and dangerousness in a client, understand that violent scenarios are stressful. They are not fun. They are not easy to deal with. Clients may describe aggressive impulses and imagery to you. You want to make sure that you document this. While predicting violence can be difficult, similar to suicide, it's a low base rate phenomenon, meaning that even if they describe this, they may still engage in that behavior, and they may still engage in that behavior without you being able to change their mind, or without you being able to do anything to change their mind. If they start describing homicidal behaviors or behaviors that are threatening the life of another person or of a large group of people, you want to err on the side of caution and get your supervisor involved to determine what the next course of action is going to be. So, some specific violent behaviors that are important to think about is that these violent predictors work best within specific populations. So you may find it in some people who have behavioral issues, some people who have higher rates of isolation or lack socialization. Typically, you find them in a lot of younger people. But there are specific violent behaviors that predict specific violent behaviors. So if someone's talking to you about fire setting, or they're really fascinated with homicide amongst young men, or anything like that, that's definitely something you want to kind of keep you know an eye on and get your supervisor involved with. If you are looking at homicidal rates amongst young men, you may find that there are behaviors that are engaged in before that. So if you're working with a client who is part of a gang, there might be more incidences and rates of violent types of behavior. So it's important that you talk about what these things are. That way you can help to safeguard that client. And again, get your supervisor involved. When you talk about those who have schizophrenia, you may find that there are violent tendencies because of the hallucinations. Again, whether they are visual, auditory, or tactile, hallucinations can cause a client to act out in a way that you don't understand because you don't hear, see, or feel the things that they are feeling. Therefore, they may become violent as a result if they're not taking their medication, or if they're not taking their medication at all, or if they're not taking it in the prescribed way. So you may find that those who have schizophrenia and they're not medication compliant, that they may have higher rates of violence that happen. So, when we look at violence prediction, this is mostly based on tightly controlled research within institutional settings such as prisons, or in mental health facilities, or even substance use facilities. In the real world, what we do is best referred to as a violence assessment. You can look at Table 12.2 for a reasonable assessment guide. So, when you look at Table 12.2 on page 456, you see here that this is a general guide to a violence assessment. So, this doesn't include the actual risk factors from two common instruments, which are the Violent Rate Appraisal Guide and the Psychopathy Checklist Revised. But if you are looking at this and you're asking direct and indirect questions about violent behavior history, you want to be alert to physical aggression and cruelty to people and to animals as well as property. If the person threatened certain types of behavior that's similar to past violent behavior, they have an elevated risk for violence in the future. Because potentially violent individuals aren't always honest about their violence history, you may need to interview collateral informants. And again, make sure that you get the releases, the written consent forms in order to do that. You want to listen for details to help identify potential victims. If the details aren't forthcoming, you may need to directly ask for those specific details. Identification of specific victim or victims increases the violence risk and provides you with information about who you need to warn. And again, you want to make sure that you get your supervisor involved with this. You also want to listen for specifics about the plan and curious and indirect questioning to assess the specificity of the client's violent plan. As we talked about with suicide, if this person has the intent to cause harm to another person, other people, or property, and they have the means and the plan with that intent to do so, that's alarming. And again, get your supervisor involved. If clients don't tell you about the access to weapons or means for committing a planned violent act, then you need to directly ask them. Access to lethal measures and means increases the risk for violent behaviors. Getting historical information about past violent behaviors or thoughts of violence is also really important. The sooner violent behavior patterns begin, the more likely they are to continue. You also may find that clients who are raised in chaotic and violent environments may have a higher risk or do have a higher risk for engaging in violence in the future. When you look at the DSM, um, the best violence predictors include items from List A of the DSM-5's antisocial personality diagnostic criteria on page 659, so make sure you check that out. You want to evaluate violence related thoughts. If the client has low expectations of being caught or experiencing consequences, or view the consequences as positive outcomes, that's a major red flag. And again, get your supervisor involved. Look at your client and substance use. Positive attitudes towards substance use, especially when carrying weapons, is a red flag. And finally, notice your intuition. So while your intuition doesn't really mean much, if you get that sinking gut feeling or you lose your breath for an instant, then you may find that there's something off, and get your supervisor involved. Make sure you have the rationale and the reasons as to why you experienced those feelings so your supervisor can support you through this. And once that session's done and you decide whatever it is that you need to do or that your supervisor is instructing to do, then you then have a debriefing session, and you may even have to have your own therapy sessions outside of your organization in order to process what that brought up for you. So, when we think about demanding situations, crisis and trauma are going to be top of the list. So, when it comes to dealing with anyone who's in crisis and dealing with trauma, you're going to find that this can cause you, as the clinician, to feel some kind of way. So, it's really important that you find ways to make sure outside of sessions that you're taking care of yourself. So, when interviewing in difficult situations, you're going to need to have advanced training with specific institutions to support your skills in these areas. So, DBT, CBT, motivational interviewing, getting trained in those measures are all great. But if you want to work with trauma clients, then TFCBT, or trauma focused cognitive behavioral therapy, is a training that you can go through in order to get specific skills that are needed to work with trauma cases. When we think about the disaster intervention guidelines, the thing that our book talks about is psychological first aid, or PFA. This has become the recommended approach for helping individuals who have experienced some type of disaster that could be a natural disaster or even a man made disaster. And there are 8 core PFA actions that we're going to be talking about. So the first is contact and engagement. So the goal in this is to respond to contacts initiated by affected persons or initiate contacts in non intrusive, compassionate, and helpful ways. So if you are receiving a list of people who have been impacted by a natural disaster, you may call out to them and just let them know who you are, what organization you're working with, for example, the Red Cross, and let them know that there are services available if they're interested in talking to someone or debriefing. The next is safety and comfort. So the goal in this is to enhance immediate and ongoing safety and provide physical and emotional comfort. That may mean helping them get their basic needs tended to, or making sure that you set them up with more longer term services such as group counseling or um, going to get support with getting longer term housing. Stabilization. When we think about stabilization, this is to calm and orient um, emotionally overwhelmed or distraught survivors. So you are essentially um, helping them because they might have a hard time comprehending the situation. So helping them get connected to social supports, um, giving them a few minutes of your time alone, using grounding techniques in order to help them to work through some of the stressors. The next is information gathering, current needs and concerns. So this is allowing for you to get the immediate needs and concerns of what's happening with this individual or these people, gather any additional information that can be helpful with this, and also to help tailor the PFA intervention. So, one of the things that can be helpful is to look at any ongoing threats that this person may be experiencing, finding a safe place for them to go with people who care about them. Um, do they need medications? Do they need stable housing? Do they have, any risks for self injurious behaviors or substance use? And if so, where can we go to get them to a safe place so they can receive potential treatment and support? That's what you do with this. The next is practical assistance. This is where you help survivors address immediate concerns and needs. So, this is where you'll gently gather more specific and detailed information about the survivor's primary problems and what might help them with that problem. You should also, support them if you find that they're having a hard time communicating what these things are. That might mean helping them with paperwork, directly helping them to make appointments by phone or online, and doing things like directly reaching out with them to their supports. The next is connecting with social supports. So, reestablishing social support connections can help facilitate stabilization and recovery for most people during a crisis or a disaster event. So these connections can be friends, family, those from a religious or spiritual group, um, current or former coworkers, current or former roommates, um, any and other organizations and personnel from within the community. So you might have to help the client to actually get in touch with these people by using, your phone or your device to, reach out to these individuals or help to find phone numbers if first say they had saved it in their phone and their phone is now destroyed. The next is informational coping support. Um, so you may provide information about things that they can do for themselves, like grounding techniques or mindfulness or yoga or meditation work, but also connecting them with local organizations and agencies that can help them to um, continue on these skills and also to help manage what they're experiencing now and also longer down the road. The final is linkage with collaborative services. So again, this is where you may be able to offer them services um, locally, get them in touch with people locally, even drive them or get them public transportation to wherever this organization is to help them to gather that support. Um, Also, you may have to have conversations about healthy versus unhealthy coping patterns. So if their inclination is to go, drink alcohol to the point of blacking out, well, that's not healthy. So maybe instead of doing that, you can help them to identify triggers and then come up with a crisis plan so that when they start experiencing these triggers, that they have people, places, and things that they can reach out to. So, what are some of your professional responsibilities? Well, beyond a PFA, therapists working in crisis or disaster situations, you have these additional responsibilities. You have ethical standards that you have to uphold. And that's not only on a state level, but it's also on the accreditation board that you are with. So the ACA, APA, NASW, or the AA, LMFT, or MFT, or whatever it is. Um, you have those in those organizations as well. So you might need a couple of things. The first is informed consent and record keeping. So there may be a need for more or less, um, there may be more or less need for informed consent, but you also want to make sure that no matter what, that you always carry extra paperwork with you, especially if you're doing something for the Red Cross. And you want to make sure that whenever possible that you get written consent, if not get verbal consent, and then have them sign something saying that they gave you verbal consent. When you are thinking about something, for example, if you're going to be a referral source, so you need to remember that people who are receiving these sources may feel out of control. So part of them and their need is to gain or regain that control. So they may need more structure and directive than is typically provided in a clinical interview. Then we have assessment decisions. So, depending on whatever your assigned duties are, it may be necessary to engage in screening activities using formal or informal assessment strategies. So, you may be monitoring people for things like shock dissociation, suicidal ideation, or homicidal ideation. You might be doing medical and physical needs, availability of social supports, ability to communicate. So you're going to be looking at their current functioning abilities and then to identify, assess, and effectively utilize different resources to help them in the immediate. So you have to think about what the nature of the crisis is, what the client's coping skills and strengths and resources are, and also what are the cultural beliefs and practices that are associated with the trauma itself. So, being able to doing screening and assessments, using the skills for doing an MSE, they're going to be certainly appropriate. And also, when you think about a diagnosis, that needs to be tentative because it's really about finding out what is happening right here and now. And adding a diagnosis on top of it can be stigmatizing for the client. The next is confidentiality. So when you think about confidentiality, this is going to be limited by the situation. And no matter what, you have a zealous obligation to protect your clients. So you want to hold their stories private, while at the same time, if there's something that needs to be relayed that is helpful for this client in receiving longer term support, then relaying that as needed. Then we look at techniques and resistance. So for many trauma survivors, they have had power and control taken away from them. So they might be ambivalent about trusting anything and anyone, including you. They are, they might be more needy than usual, or they may become very suspicious of you. Part of that suspicion is also being very guarded and resistant. So understand that going in, and the tips that we talked about in the beginning of this lecture with resistance can help you in supporting them. There's also secondary or vicarious trauma. So, when we think about this, this is where they can re experience the trauma via flashbacks or nightmares, where they have negative cognitions or mood, meaning that they self blame and hold a lot of guilt and shame within them, and also arousal. So, they might become hypervigilant. So, remember, when working with trauma survivors, attending to basic needs is essential. It's also essential for you to be able to take care of your basic needs. Because if you don't take care of yourself, it's going to be harder to take care of others. There's also boundary concerns. When we think about boundary concerns, it can be difficult to maintain proper therapeutic distance, especially in crisis and disaster situations. There might be heightened attraction, both for you to the client to you. And that can be referred to as trauma bonding and can lead to some unhelpful and even unethical behaviors. If you believe that this is occurring, it's important to talk to whoever's in charge and to step away from that situation as quickly as possible. Another important boundary issue is self referral. So don't refer yourself unless there's no other option in that region. And even then, the referral must be approved by a national office, so through your state or through the licensing board, to make sure that you are not doing this for your own financial gain and benefit. That is frowned upon, and you could lose your license as a result. When we are thinking about interviewing trauma survivors, something for us to think about is that trauma can be things like natural disasters, school shootings, workplace shootings, sexual assault, war related violence, um, a number of different things. They're often, the experiences themselves are typically immediate and have longer term emotional and psychological symptoms. So I encourage you to check out the book. The book is really straightforward from page 466 to 468. They do a really great job of what it means to interview trauma survivors. Something to think about when you're interviewing trauma survivors is to look at the issues and the challenges that they're facing. It's important to ask specific questions and to be empathetic, as empathetic as possible, and let them know, normalize and validate the discomfort, the shame, and the guilt that they've experienced. When we look at cultural competencies in disaster mental health, remember that there may be little time to prepare or to seek adequate cultural knowledge. So it's important that you do the work longer term. So before something like this arises, whatever this is, it's important to have an understanding of different cultural backgrounds. And as we've talked about in previous chapters, when in doubt, ask the clients. Ask what's appropriate for them. Ask what they need from you. When you think about competencies, there are hundreds of competencies that exist. So you're not going to know every single one, but having a basic understanding of what some of them are can be really helpful. When we are looking at the DHHS, we are looking at how um, we can, which is the DHS, excuse me, the DHHS is the Department of Health and Human Services. They have a free resource, which I encourage you to order, but they look at mental health cultural competencies for disaster relief settings, and they are widely accepted. And they talk about things like recognizing the importance of culture and respect with diversity, recruiting disaster workers who are representative of the community or the service area, ensuring that services are acceptable, appropriate, and equitable, assessing and evaluating the program's level of cultural competence, recognize the role of help seeking behaviors, customs and traditions, and natural support networks. They try to be as inclusive as possible. So, for those who are affected, those who are supporting them may be from their same background, which can be really helpful. When you return back to cultural humility, something to think about is that embracing cultural humility will help you to be more effective in crisis and trauma situations. So you want to embrace what others are about outside of who you are. You want to hold high your respect for diversity in cultural values and ways of being. And you want to let go of any ideas that you may have related to your own superiority. That's why it's so important, starting now and throughout your personal and professional careers, that you understand different levels of privilege and understand different backgrounds, and to understand how these different backgrounds may have experienced, you know, situations that lead them to not trust or not believe or not, consider the value that therapy can offer. I hope that this was helpful for you. As always, if you have any questions, comments, or concerns, please feel free to reach out to me via email. Otherwise, check out the description box below for your extra credit question. All you need to do is answer the question in the comments, take a screenshot, and upload it for up to 1 point added to your final grade. Until next time, I hope you have a great day and be well.